It's time for neurology session. I have a great honor to present our chairperson, Dr. Fatma Al-Gallaf, consultant pediatric neurologist, Mubarak Hospital, Dr. Osama Shalabi, senior specialist pediatric neurology, our Jahra Hospital. Welcome.
Assalamu alaikum, everybody. I'm very happy and glad to be with you in this conference. Actually, it's a successful conference. I congratulate Dr. Saad and everybody here. The attendance is very great, and I hope you will continue the other years like this. We will come to the most attractive part of our conference, at least in my opinion, neurology. And it's my pleasure to introduce Prof. Tarek Omar, sorry. He's a professor of pediatric and pediatric neurology department in Faculty of Medicine, Alexandria University, from 2007 till now. Prof. Tarek, he had his Bachelor of Medicine and Surgery in 1986. He had his master degree in pediatric 1991. He has his doctorate degree in pediatric 1996. Then he had so many posts as a head of so many departments. He had his postgraduate trainee fellowship between 1994 and 1995. In pediatric neuroscience, Royal Hospital of Sick Children, Department of Child Life and Health, Edinburgh University, UK. And please welcome Prof. Tarek with me.
Bismillah ar-Rahman ar-Rahim. I'm really thankful for Dr. Fahd Al-Anezi, Dr. Osama Shalabi for inviting me to share with you this magnificent conference. Thank you, Dr. Fatma Al-Gallaf. Thank you, Dr. Osama. Thank you, my colleagues, pediatricians here, whether from Egypt or from Kuwait or from other countries. I'm really delighted to share with you this conference. And greetings from Alexandria and greetings from my hospital beside the library. This is the library. And this is the hospital, Alexandria University Children's Hospital. Pediatric headache is a very, very common and public health issue. And it's really a very controversial in its management. So the topics which I'm going to cover today, the headache as a public issue, types of pediatric headache according to the International Classification of Headache Disorders by the International Headache Association, challenges in pediatric headache, pathways of pediatric headache management, assessment in pediatric headache, and the clinical management and the clinic tools in pediatric headache. Why is it a common health problem? Number one, it is very frequently reported among children, even more frequently than others. When I was in Scotland more than 20 years ago, I remember that there was a migraine clinic in the hospital where I have been trained of. This was 20 years ago. Secondly, it has a strong impact on the school performance. Some children might be absent from schools, or they might stop their activities because of this headache. And lastly, because of the costs related to the management, including the diagnosis and the treatment. The lifetime prevalence of headache disorders ranges between 70 to 80% in children of the age 13 to 15 years of age. It affects about 3 to 8% of children more than 3 years, and then it goes rising upwards until it reaches the adolescence. It is higher in frequency among the males compared to the females with regard before puberty, and then they are commoner in females after puberty. In infancy and early childhood, headaches are very rare and they should be taken very seriously, especially if they are younger than 3 years of age. And this is because most likely they are going to have an organic cause or secondary headaches. And that's why there was a WHO campaign for management of the common headache disorders in the primary care. So I feel that the choice of this topic for me, for myself, from the scientific conference was an excellent choice. Based on the International Classification of Headaches Disorders, which was published by the International Headache Society in 2013, the childhood headaches could be acute recurrent, chronic progressive, non-progressive, and mixed types. And the types which we used to see, the types which we used to see in the primary care, of course, the migraine, and there is the tension type headache, the cluster headache, and there is a very common possibility, which is a medication overuse headache, which means rebound headache. The more we give medicines to the children, the more they will have the headaches. And this category also includes the secondary headaches because of a pre-existing headache disorder or a common organic etiology. According to the International Headache Society classification, we know that migraine, we have 5 attacks fulfilling the criteria of lasting 1 to 72 hours, and the headache should have at least 2 of the following 4 features: bilateral or unilateral frontal temporal location, pulsating in character, moderate to severe intensity, aggravated by routine physical activity, and at least one of the following accompanies headache, either nausea or vomiting, photophobia, phonophobia, which may be associated. Within the clinical guidelines of pediatric headache, which have evaluated all the guidelines by the agreed to instruments, it was found that all the guidelines that deal with this condition, usually they are of low moderate quality and non-homogeneous. And the conclusion was to have major efforts to update the existing guidelines according to the principles of the evidence-based medicine. And so the pediatric headache actually is a challenge. Why? Because the diagnosis is surprisingly poor. It is frequently not adequately investigated. We don't have very adequate, sensitive, and specific diagnostic criteria. And the most important of all, in the pediatric emergency department, the children might have undergone unnecessary investigations and even unnecessary interventions which might be harmful. That's why internationally there are many hospitals who have published consult and referral guidelines for the headaches. And these guidelines might include what should we evaluate initially by the child, what sort of instructions should be given to the parents, and when I'm considering to do investigations and the quality of these investigations, and then when I have to refer to a pediatric neurologist, and finally, what should I ask the families to bring with them to the pediatric neurologist. And within these hospital-based guidelines, the patient will be presented by headache. So we have complete history, physical examination as screening tools, including identification of the psychosocial problems. Are there any red flags? If there are no red flags, then we classify the headache according to the primary categories, and we begin headache treatment, and we keep a headache log for the condition on follow-up. If there are red flags, then we begin neuroimaging, we do consultation or referral, and then we begin appropriate treatment in collaboration with this subspecialty, and again, we end up with keeping a headache log for monitoring the condition. What are the red flags? The red flags are in the history and the physical examination. So within the history, if there is no family history of headache, this is, might be alarming. If there is lack of response to the medical treatment by analgesics, this could be alarming. The headache which comes early in the morning, especially if it is associated or not associated with vomiting. If the headache awakens the child from sleep, if the headache is associated with persistent vomiting, the headache which is associated with Valsalva maneuver, like coughing or vomiting or bowel movements, the chronic progressive headache, and if the patient is going to describe this headache as the worst headache he has ever had, if he's unable to describe the pain, this is again alarming, recurrently localizing headache, and if there is personality changes or neurological manifestations. Within the physical examination, the red flags are the age is less than 3 years, and if there is a known risk for intracranial pathology, like having shunt malfunction or neurocutaneous syndrome, or if there is abnormal neurological examination findings, including seizures and deteriorating consciousness. Now, we have very specific questions which we should cover within the history. How many headache types that the child is having? And for each type, we should have specific items. So we ask about the time questions which related to the temporal profile of the headache. How recent? How did it develop? What is the peak? What is the usual time? And so on. Questions related to the character of the headache or the feature of the headache, how is it intense, what is the nature and the quality, the site and the spread, and then are there any predisposing or triggering factors, and what about the response to any medications that have been given during the attack, and what is the state of the health in between the attacks of the headache. And then we go by focused physical examination. This is general physical examination, including the simple issues like vital signs, examination of extracranial structures, and neck examination. And then we go to focused neurological examination, looking for abnormal neurological findings, including ophthalmological examination, cranial nerves, and neuromotor system. And then, the causes of concern, as we have said, if the headache is subacute or progressive, if it is a different or new headache which is being stated by the patient, any headache which is maximally severe at the onset, and if the headache is, as I have said, it is precipitated by Valsalva maneuver, any other associated systemic manifestations, neurological signs, and seizures. And then, according to the guidelines, the radiological investigations, they include both the CT and the MRI. The CT scan might be preferred if the headache is severe and of abrupt onset. This might signify hemorrhage, so the CT will be of prior indication. If the headache is attributed to infection, then the CT should be done before the lumbar puncture. And if the headache is attributed to trauma, again, the CT scan will be preferred. If the headache is occipital in localization, then the MRI will be preferred because it is very difficult to visualize the posterior fossa in the presence of MRI. And in most urgent situations, usually the CT scan is obtained, and it can give very adequate information before proceeding to the MRI scan. So the CT scan with evidence B could be considered if the headache is acute, if the headache is so severe, if there is new focal neurological deficit, if there is intracranial intractable vomiting, papilledema, or fever. While the MRI, if there are any other red flags, especially if more than one combination, and if the headache occurs during the night and awakening the child from sleep. Lumbar puncture, this is mandatory in all febrile patients with nuchal rigidity. It might be indicated with measurement of the opening pressure if there are suspicions about the subarachnoid hemorrhage, and if the consciousness of the patient is deteriorated and papilledema is suspected with or without focal neurological findings, CT scan is preferably done before the lumbar puncture. The EEG, with a quality of evidence D, this is of very limited use in routine evaluation of a headache. It has nothing to do with the headache diagnosis. It might be needed only if the headache is very momentarily and associated with altered consciousness or abnormal movements, but as a routine, not indicated. Referral, it means referral from the primary care pediatrician to the neurologist. If you've got red flags in the history, physical examination, or radiological findings, and again, there should be items to be sent to the neurologist, including copies of the medical records, laboratory reports, and imaging studies, all medications that have been prescribed, and 2 months calendar of the headache condition. The clinical management, we start by the behavior modification, which is extremely important. All the children, as well as their parents, should be counseled to have a headache hygiene, which means very healthy habits, like drinking enough fluids, having enough sleep, having good balanced diet three times a day, and avoiding the triggering factors, exercising and stretching, stress management, and avoiding use of electronics. And then the general recommendations for treating the acute attacks, we have to have a treatment plan, and this treatment plan should be done at home and at school. We start by the non-pharmacological options with the fluid replacement, the first line medicine to be given at the onset, and then a second line treatment to be given 2 hours if the headache is persistent. And the first line should include non-sedating medication.
Excuse me, Prof. Tarek, 5 minutes left.
The key to start the treatment at the onset of the headache, especially if we are going to use triptan, and monotherapy is strictly indicated. As we have said, many non-pharmacological agents which are related to the behavior medication should be included. The use of relaxation techniques and biofeedback modalities, they have objective data to be used, especially if the headache is disabling. We have relaxation therapy or biofeedback mechanisms. And then we come to the pharmacological treatment. The ibuprofen is the safest and first line, or the acetaminophen. The sumatriptan nasal spray, could be an effective as a second line treatment. However, other drugs like the oral triptans or subcutaneous triptans are not having sufficient evidence. As we have said, we have a home and school plan, starting by the first line, then the second line, according to the response to the drugs. We have said that the preventive therapy, the non-pharmacological options, again, are extremely important. We start medications if the headache occurs 3 to 4 times per month. And we have to start very slow and go slow, and to discontinue the treatment once the effect is achieved, reducing the dose by 25% every 2 weeks. The most effective is the flunarizine, however, there is no sufficient evidence for many other drugs which are in common, like cyprohepatidine, topiramate, sodium levetiracetam, and even propranolol or pizotofen. All these don't have a very sufficient evidence to be used on a routine basis for prevention. Lastly, the provider tools. The parents should have a headache intake questionnaire, which is questionnaire related to the condition. The headache education, caregiver education for the parents, and the headache diary. This is sample for the headache intake questionnaire, and these are the items to be given during education, and the headache diary which could be used. And very importantly, the follow-up measurements according to the severity of the condition. And thank you very much.
Very much. Prof. Tarek for the great lecture about headache. And if anybody is having any question.
شكرا دكتور طارق. أردت to ask, can electronic devices cause headache up to convulsions?
The only association with electronic devices like the TV, like exposure to intermittent flashing lights, it's like intermittent photic stimulation, which you do it as an activation procedure for EEG recording. And we cannot mention that they are prohibited unless the actual attack occurred during playing with these games. We used to say we should have screens over the TVs or over the computers. All now are not needed, and there is no contraindication for playing with the game, with the electronic devices or the TV or with the computer if the child is having seizure, as long as the seizures are not precipitated by such games.
You rank the commonest three causes of headache. For example, in a child from 5 to 10 years, what are the most common causes?
From 5
5 to 10 years.
for 5 to 10 years. If you are talking about primary headache, definitely the migraine is the most common. This is something like 10% of the children out of 100. We have 10 children having migraine headache, which is very common, and sticking to all the criteria for diagnosis. And then you go for the tension type headache, which again the second common among children, and then you go for any organic causes, whatever post-traumatic or infectious or sinusitis, for example, or ophthalmological problems. Yeah.
Thanks, Dr. Tarek, for your nice talk. We have a question here. Al Jahra Hospital, we have a lot of patients with headaches coming to our neurology OPD. For the message you give when to refer and the red flag, this is a very sound for us. We receive a lot of referral, and some patients I have received done 3 CTs before coming to our OPD. Dr. Osama have a lot of patients more than us. The message when to refer the patient, and along the last 8 years, I have only 2 patients with intracranial tumor, or 1 patient with this idiopathic increase of intracranial pressure as a cause of headache. The question in migraine actually for us, when to use paracetamol, as you said, and ibuprofen, and when to use intranasal somatriptans. And the second question is about the prophylactic. You mentioned only 1 drug, although in the literature a lot of like anti-epileptics and anti-arrhythmic propranolol. What is the exact role, if we are familiar with one of them, like Tobamax or Inderal? Thanks.
The first question is related to the use of nasal somatriptan.
Yeah.
Usually the somatriptan is preferred starting from adolescence. We are talking about more than 12 years of age. This is the first question. And ibuprofen could be very safe and very effective if it is used at the onset of the headache or at the onset of the aura. And there are many combinations which might include paracetamol and metoclopramide if there is very pronounced nausea and vomiting. And it is very, very effective. For the preventive therapy, you've mentioned, I have mentioned flunarizine as the only effective drug with regard to its evidence. All other drugs, they lack a very strong evidence to be used. The propranolol, the topiramate, these are the pizotofen, these are the most common drugs which we are using, and they are in the market. But still, they don't have a very strong evidence to be used very frequently. And I have many children who fail to respond to topiramate, for example, and they are responding very well to flunarizine.
So let's say, for example, the patient comes 2 years old with signs of meningitis, and the same exam is remarkable still for the patient. Can I do for him CT before the LP, and if so, I'm going to do CT? Can I start antibiotic before the LP or not?
My answer will come in my next presentation about the febrile seizures. Could it be prevented? When do you do lumbar puncture? if the child is having suspected meningitis. This is, and the second question, would you do CT scan before the lumbar puncture or not? As a routine basis, lumbar puncture, CT scan is indicated if you are deciding to do lumbar puncture in all children between less than 12 to 18 months age. It is indicated you have to do CT scan before lumbar puncture. Because in this situation, the diagnosis of meningitis might be difficult, and there might be lacking of meningeal signs among those children. So your decision to diagnose meningitis will be based upon high index of suspicion and then lumbar puncture. And in this case, lumbar puncture, you have to do the CT scan before. Okay.
Okay, we'll take the last question, or that's it.